what truly underpins the body's ability to heal and recover, especially after something as profound as surgery. Many might think of stitches or perhaps medication, and while those are absolutely crucial, the unsung heroes, the microscopic forces working tirelessly behind the scenes, are often overlooked. The precise balance of fluids and electrolytes. It's a foundational science, one that the most elite professionals and surgical care master to an incredible degree.
It really is. It's more than just foundational. It's the very bedrock of patient care that surgeons and medical teams, well, they obsess over it. This intricate balance is absolutely vital for maintaining crucial homeostasis, that stable internal environment. It allows everything from cardiovascular perfusion, the flow of blood through tissues, to organ system function and complex cellular mechanisms to respond effectively to the immense stress of surgical illness or trauma. Without this precise balance, the body simply cannot cope, and recovery becomes, well, almost impossible.
And in this deep dive, our mission is to truly equip you with that mastery-level understanding. We're not just skimming the surface, we're plunging deep into the intricate world of body fluids and electrolytes. We'll uncover precisely how these vital components maintain life, what happens when they go awry in the demanding surgical context, and the sophisticated, often precise strategies professionals use to restore that delicate balance. Think of this as your pathway to mastering this critical information, just like the elite in the field.
Yeah, and our guide for this journey comes from the foundational knowledge found in Schwartz's Principles of Surgery. It's an authoritative source, a really deep well of information. We've distilled and expanded upon the most critical insights to provide you with an in-depth understanding, the kind you need to truly grasp this complex yet absolutely essential topic. So understanding fluid and electrolyte management is paramount to the care of any surgical patient. Whether it's pre-op, intra-op, post-op, or, in response to the massive physiological shifts seen in trauma and sepsis, it's the constant underlying challenge. So let's unpack this, really getting into the nuts and bolts and building our understanding from the ground up.
Okay, so to truly achieve mastery here, we have to start with the basics. What are body fluids and how are they organized within us? Our first major stop is total body water, or TBW. It's astounding just how much water makes up our bodies, isn't it?
It absolutely is. Water constitutes approximately 50% to 60% of our total body weight. That's huge. Now, this percentage, while remarkably constant for an individual, it does vary significantly based on body composition. To put it simply, lean tissues like muscle and solid organs contain a much higher percentage of water compared to, say, fat and bone. This means that body composition directly influences this fundamental aspect of our physiology. Right. So if a young lean male averages 60% TBW, how does that compare to, say, a young adult female or someone older or perhaps obese? What are the precise variations clinicians have to account for?
That's a crucial distinction in clinical practice, absolutely. A young, lean male, as you noted, typically has about 60% TBW. In contrast, a young adult female averages around 50% TBW. This is primarily due to their generally higher percentage of adipose tissue and lower muscle mass. Now, as individuals age, or if they are obese, that percentage tends to decrease further because, well, fat contains very little water. So when clinicians estimate TBW for therapeutic calculations, they'll actually adjust it downward by maybe 10% to 20% for obese individuals, recognizing their lower proportion of water. Conversely, for malnourished individuals who might have lost a lot of lean mass but also be dehydrated, the estimation might be adjusted upward by 10%. And it's also quite fascinating, that newborns have the highest percentage, approximately 80% TBW, and that decreases relatively quickly to about 60% by the time they reach 1 year of age. It really highlights just how dynamic this fundamental aspect of our physiology is from birth through adulthood.
Okay, so once we understand the total volume of water, the next logical step is exploring how that water is distributed. The body isn't just one large reservoir, right? It has this incredibly sophisticated internal plumbing, dividing its fluids into specific compartments, each with its own characteristics.
That's absolutely right. Total body water is functionally divided into 3 main compartments, and understanding these divisions is, well, foundational for surgical fluid management. First, we have plasma. That's the fluid component in our blood, effectively the intravascular fluid. This makes up about 5% of total body weight. So for a typical 70-kilogram male, that's roughly 3,500 milliliters. Second, there's the extravascular interstitial fluid. This is the fluid that bathes the cells, essentially filling the spaces between them. This accounts for about 15% of body weight, or maybe 10,500 milliliters in that same 70-kilogram male.
And then the largest and perhaps most complex compartment.
That would be the intracellular fluid, or ICF. This is the fluid inside our cells. and it's by far the largest proportion, making up about 40% of body weight. That's a whopping 28,000 milliliters in a 70-kilogram male. The largest proportion of this intracellular fluid is found, quite logically, within our skeletal muscle cells. They're metabolically very active and contain a lot of water. It's important to note, too, that the plasma and interstitial fluid together are often referred to as the extracellular fluid, or ECF. This ECF constitutes about 1/3 of the total body water, or roughly 20% of total body weight. It's the compartment that directly communicates with the external environment, and it's where most clinically significant fluid shifts initially occur.
And the movement between these compartments, how water and solutes flow between them, that's crucial to understanding disease states and how our bodies try to compensate, isn't it?
It's absolutely fundamental. The knowledge of these compartments and how fluids move between them is paramount to understanding how pathological shifts occur in various disease states, particularly in surgical patients. Water itself is freely diffusible across cell membranes. It can move relatively unhindered between all fluid compartments to equalize osmotic pressure. However, sodium. Sodium behaves quite differently. Sodium is largely confined to the ECF, and because of its unique osmotic and electrical properties, it essentially dictates water distribution within the ECF. This is a critical insight. When you administer sodium-containing fluids intravenously, you're not just expanding the intravascular volume, you're expanding both the intravascular and interstitial spaces. What's particularly fascinating and often overlooked is that the interstitial space expands approximately 3 times as much as the plasma volume. This has profound implications for how we manage fluids, as a seemingly small amount of fluid in the bloodstream can lead to much larger shifts into the tissues, potentially causing edema.
So we have these compartments defined by their location, but they're also chemically distinct. It's not just water moving around, it's water with specific dissolved components, each playing a vital role. What's the chemical blueprint of these different fluid compartments?
That's where the true complexity and beauty of fluid balance lies. The specific ionic composition is key to their function. In the extracellular fluid, or ECF, that's the plasma and interstitial fluid combined, the principal cation, the positively charged ion, is sodium, Na+. The principal anions, or negatively charged ions, are chloride, Cl, and bicarbonate, HCO3. So you can think of sodium, chloride, and bicarbonate as the dominant chemical players in the fluid outside our cells.
And inside the cells, in the intracellular fluid, it's a completely different mix, almost an inverse of the ECF, right?
Precisely. The intracellular fluid, or ICF, is primarily composed of the cations potassium, K+, and magnesium, Mg2+. And its major anions are phosphate, PO43, and sulfate, SO42, along with a significant amount of proteins, which are large, negatively charged molecules. What's truly remarkable is how the body rigorously maintains these steep concentration gradients between the compartments. It's not passive, it requires constant active work. Adenosine triphosphate ATP-driven sodium-potassium pumps, these are specialized protein channels located within every single cell membrane, actively work to keep these gradients in place. They're constantly pumping sodium out of the cell and potassium into the cell against their concentration gradients. This active transport consumes a significant amount of the body's energy.
And what about the differences between plasma and interstitial fluid? They're both part of the ECF, so are their compositions identical, or are there subtle but important distinctions?
They're very, very similar in their ionic composition, almost identical from a practical perspective for most electrolytes. But there is a crucial, subtle difference. Plasma has a slightly higher protein content compared to interstitial fluid. These proteins, being large molecules, act as organic anions and are largely confined to the intravascular space. Due to something called the Gibbs-Donnan equilibrium equation, this slightly higher protein content in plasma leads to a slightly higher plasma cation composition compared to the interstitial fluid. This difference is clinically important because the proteins in plasma, particularly albumin, contribute significantly to its osmolality and are crucial for maintaining fluid balance across the capillary endothelium. That's the semi-permeable membrane where exchange happens, and the proteins exert an osmotic pull that keeps fluid within the vascular space.
Speaking of osmolality, that leads us perfectly into osmotic pressure. It sounds like a very technical term, but it's essentially the driving force of water movement across cell membranes. How do we measure these forces in the body, and what units do we use?
You're right, it's the fundamental principle governing water movement. When we talk about measuring these forces and the concentration of solutes, we use a few key units. First, there are millimoles per liter, OMO. This simply tells you the number of particles by unit volume, a direct measure of molar concentration. Then we have milliequivalents per liter, MEQL, which is crucial because it accounts for the number of electric charges per unit volume. This is really important for electrolytes that carry different valences. The equivalent of an ion is its atomic weight in grams divided by its valence. So for a univalent ion like sodium, Na+, 1 millieq is the same as 1 millimole. But for a divalent ion like magnesium, Mg2+, 1 millimole actually equals 2 LeQ because it carries 2 positive charges. A foundational principle here is that the total number of cation MEq must always balance the total number of anion MEq to maintain electrical neutrality within any fluid compartment.
And then there's milliosmoles per liter, mNml, which specifically quantifies the number of osmotically active particles. Can you give us an example to clarify that?
Certainly. This unit is vital for understanding osmotic pressure. For example, 1 millimole of sodium chloride, NaCl, contributes 2 milliosmoles to a solution, one from the sodium ion, Na+, and one from the chloride ion, Cl, because both are osmotically active particles. This concept of osmolality directly relates to osmosis. That's the passive movement of water across a semi-permeable membrane from an area of higher water concentration, lower solute concentration, to an area of lower water concentration, higher solute concentration. It's all in an effort to equalize solute concentration and achieve osmotic equilibrium.
So what are the primary determinants of serum osmolality that clinicians focus on? And why is that important in a clinical setting, especially for surgical patients?
The principal determinants of serum osmolality are the concentrations of sodium, glucose, and urea, which we commonly measure as blood urea nitrogen, or BUN. These are the big three. Clinicians can quickly estimate serum osmolality using a specific formula. Calculated serum osmolality equals 2 sodium plus glucose 18 plus BUN 2.8. This formula provides a rapid practical estimation of the total osmotic activity in the blood, which is, well, invaluable.
And what's a normal range for this, and why does it matter so profoundly for patients, particularly those undergoing surgery?
Both intracellular and extracellular fluids maintain a remarkably tight osmolality balance, typically falling within a narrow range of 290 to 310 millivolume. This tight regulation is absolutely critical for cellular integrity and function. Any deviation, even a subtle change in osmotic pressure in one compartment, immediately leads to a redistribution of water until that equilibrium is painstakingly restored across cell membranes. From a clinical perspective, especially in surgical care, it's vital to remember that most significant fluid gains or losses occur directly from the extracellular compartment. This is where the initial, often dramatic impact of a fluid shift is most often seen and needs to be addressed with precision. Understanding this principle is fundamental to anticipating, diagnosing, and effectively managing a patient's fluid status, preventing severe cellular dysfunction, particularly in the brain.
Okay, so with that foundational understanding, let's pivot to the dynamic shifts that occur in surgical patients. Because surgery, trauma, even just the fasting period before an operation can dramatically alter these finely tuned balances. Let's start with the normal daily exchange of fluid and electrolytes, the daily balance in a healthy baseline person.
Right. In a healthy individual, the body is constantly engaged in this meticulous dance of fluid intake and loss, maintaining a precise equilibrium. On average, we take in about 2,000 milliliters of water per day. Approximately 75% of that comes from oral intake, simply drinking, and the remaining 25% is extracted from the water content of solid foods. It's a remarkable, almost unconscious balancing act.
And what about the ways we lose water?
Yeah.
Because it's far more nuanced than just what comes out as urine, isn't it?
Yeah, absolutely. Daily water losses are multifaceted and need to be understood in detail for clinical mastery. The most obvious is urine, typically 800 to 1,200 milliliters per day in a healthy adult. However, it's critical to remember that to effectively clear metabolic waste products like urea and creatinine, the kidneys need to excrete a minimum of 500 to 800 milliliters of urine daily, regardless of oral intake. We also lose about 250 milliliters in stool. Then there are what we call insensible losses. These are water vapor losses, meaning no electrolytes are lost with them, and they total around 600 milliliters per day. About 75% of these insensible losses occur through the skin, evaporating directly, and 25% occur through the lungs during respiration. These insensible losses can significantly increase with factors like fever, where metabolism is elevated, in states of hypermetabolism like severe infections, or during hyperventilation, where increased respiratory rate leads to more water vapor expelled.
So those are the unavoidable baseline losses. But then there are also sensible losses, which involve electrolytes as well as water, and those can vary hugely, especially in surgical contexts.
Yes, and these are often the most problematic in surgical patients. Sensible losses include things like sweating, which is typically a hypotonic fluid, meaning it causes only a small sodium loss per liter, but can amount to significant volume. However, the really significant sensible losses in surgical patients often come from pathological gastrointestinal fluids. Think about patients with severe vomiting, profuse diarrhea, high output intracutaneous fistulas, or even excessive nasogastric suctioning. The volumes and electrolyte concentrations of these GI secretions from the stomach, small intestine, colon, pancreas, bile, they vary widely depending on their origin. For instance, stomach fluid is high in chloride, while small intestinal fluid is closer to plasma. These fluids are typically isotonic to slightly hypotonic relative to plasma, meaning they can have a substantial impact on both overall volume and free water balance. They require precise measurement and replacement with usually isotonic salt solutions to maintain stability.
So when things go wrong in surgical patients, these normal exchanges are thrown off. The way we classify these body fluid changes helps us diagnose and treat them. They fall into three main interconnected categories, right?
That's a critical distinction to master. We rigorously look at disturbances in A, volume, B, concentration, and C, composition. It's crucial to understand that while these can all occur simultaneously in a complex surgical patient, complicating the clinical picture, each is fundamentally a separate entity. They have their own unique underlying mechanisms, and therefore each requires individual, often distinct, correction strategies. You can't just treat one and expect the others to fall into line.
Could you elaborate on the precise distinctions between these three types of changes? This is where true understanding begins, I think.
Certainly. A volume change typically involves an isotonic gain or loss of a salt solution, meaning the concentration of solutes remains similar to normal extracellular fluid. This primarily impacts the extracellular fluid, or ECF, volume. Because the osmolality remains largely the same, there's very little shift of water into or out of the intracellular fluid, the ICF. So the ICF volume is largely unaffected. An example would be acute blood loss or the rapid infusion of normal saline. In contrast, a concentration change occurs when there's an addition or loss of free water from the ECF relative to solute. Because water is freely diffusible across all cell membranes, this causes water to rapidly shift between the ECF and ICF until the osmolality, the solute concentration, equalizes between the compartments. Sodium, being the primary determinant of ECF osmolality, is a key player here. Think of conditions like hypernatremia or hyponatremia. Finally, compositional changes are alterations in other ECF ions, not sodium, without a significant change in the total number of osmotically active particles. These result in changes to the chemical blueprint of the fluid, like potassium or calcium imbalances, without necessarily causing large-scale water shifts between compartments. Understanding these precise distinctions is paramount for targeted effective therapy and avoiding, iatrogenic harm.
Okay, so let's talk about the visible impact of these fluid balance disturbances. Let's start with what's arguably the most common fluid disorder in surgical patients: extracellular volume deficit or hypovolemia.
Hypovolemia is indeed the most frequent fluid disorder we encounter in surgical patients. It can be either acute, developing rapidly, or chronic, developing over a longer period. And the clinical signs differ importantly. With an acute volume deficit, the body's compensatory mechanisms kick in, and you'll primarily see cardiovascular and central nervous system signs. Think tachycardia, orthostasis that drop in blood pressure upon standing, and changes in mental status like confusion or lethargy. With the chronic deficit, those cardiovascular and CNS signs will still be present, but in addition to them, you'll start to see more subtle tissue signs, like decreased skin turgor, where the skin slowly returns to normal after being pinched, or sunken eyes, which reflect prolonged cellular and interstitial depletion.
And what about the lab findings? What crucial diagnostic clues might they provide?
Laboratory examination in hypovolemia can reveal several key indicators. You may see an elevated BUN level, blood urea nitrogen, and an elevated BUN to creatinine ratio, especially if the deficit is severe enough to reduce glomerular filtration rate, GFR. It impacts kidney function due to reduced blood flow. You might also observe hemoconcentration, meaning the blood appears thicker due to a decreased plasma volume, leading to an elevated hematocrit and hemoglobin concentration. The urine osmolality will usually be significantly higher than the serum osmolality, indicating the kidneys are trying hard to conserve water. And importantly, urine sodium will typically be low, generally less than 20 ml EQL, as the kidneys attempt to conserve sodium to preserve volume. It's crucial to remember, though, that serum sodium concentration itself doesn't always directly reflect volume status. It can be high, normal, or low, even when a significant volume deficit is present. A full clinical picture is essential.
Given its prevalence, what are the most common culprits behind this hypovolemia in surgical patients? Understanding the cause is key to prevention and treatment.
Well, the most common causes are significant losses of GI fluids. Things like continuous nasogastric suctioning, severe vomiting, profuse diarrhea, or high output enterocutaneous fistulas. But beyond these external losses, we also frequently see significant fluid sequestration, often referred to as third space losses. This is where fluids move out of the functional circulating volume into a third space, a non-functional interstitial space. This can happen with massive soft tissue injuries, extensive burns, or severe intra-abdominal processes like peritonitis, bowel obstruction, or even during prolonged major surgery. Fluid pools in the abdomen or tissues due to inflammation and capillary leak. This sequestered fluid is effectively lost from the circulating volume, even though it hasn't actually left the body.
Okay, on the flip side, then we have extracellular volume excess or hypervolemia. What are the common scenarios where we see too much fluid in surgical patients, and what does it look like clinically?
Hypervolemia can often be iatrogenic, meaning it's caused by medical intervention, like overly aggressive or inappropriate intravenous fluid administration that happens. But it can also be secondary to underlying conditions that impair the body's ability to excrete fluid. Things like renal dysfunction, congestive heart failure, or cirrhosis with portal hypertension. In hypervolemia, both plasma volume and interstitial volumes are significantly increased.
And what are the classic symptoms a patient might present with that would signal this excess? What are the red flags?
The symptoms are primarily pulmonary and cardiovascular, reflecting the fluid overload. You'll observe signs like pulmonary edema fluid accumulating in the lungs, leading to shortness of breath or crackles on lung auscultation, increased cardiac output, distended neck veins, indicating elevated central venous pressure, and an increased central venous pressure reading if measured directly. Peripheral edema, swelling in the extremities, is also common. In otherwise fit patients, a moderate volume excess might initially be well tolerated, presenting mainly as peripheral edema and a hyperdynamic circulation. However, for elderly patients or those with pre-existing cardiac disease, even a moderate volume excess can rapidly and dangerously lead to serious complications, like acute congestive heart failure and severe pulmonary edema, requiring urgent intervention. This underscores why careful, individualized fluid management is so critical.
So the body has these remarkable complex ways of regulating volume and concentration. It uses sophisticated internal sensors like osmoreceptors and baroreceptors. How do these systems work together to keep us in balance, and how do they respond when things go awry in a surgical patient?
These are truly the body's internal command and control centers for fluid balance. Osmoreceptors are specialized sensory neurons, primarily located in the hypothalamus. They detect even minute changes in fluid osmolality, that concentration of solutes in our body fluids. When they sense an increase in plasma osmolality, for example, signaling dehydration or increased solute concentration, they trigger two main responses. They powerfully stimulate thirst, encouraging us to drink more water, and they also drive changes in diuresis through the kidneys. Simultaneously, the hypothalamus is stimulated to secrete vasopressin, also known as antidiuretic hormone, or ADH. ADH then acts on the kidneys, primarily on the collecting ducts, increasing water reabsorption. Together, these precise mechanisms work to bring the plasma osmolality back to its normal, narrow range, restoring osmotic equilibrium.
And what about baroreceptors? They sound like they deal with pressure, but how do they integrate with fluid volume?
Exactly. Baroreceptors are specialized pressure sensors strategically located in key areas like the aortic arch and carotid sinuses. They modulate fluid volume in response to changes in blood pressure and circulating volume. When they detect a decrease in blood pressure or circulating volume, they initiate a complex cascade of responses. These responses are both neural, operating rapidly through sympathetic and parasympathetic pathways to adjust heart rate and vascular tone, and hormonal. Hormonal responses involve a complex interplay of substances, including the renin-angiotensin-aldosterone system, atrial natriuretic peptide, AMP, and renal prostaglandins. The net result of these integrated multi-system responses is to alter renal sodium excretion and free water reabsorption, ultimately striving to restore the circulating volume and blood pressure to normal. So these two systems, osmoreceptors for concentration and baroreceptors for volume pressure, work in exquisite concert to ensure vital fluid homeostasis.
Now let's dive into the absolute cornerstone of concentration changes, focusing specifically on sodium. Its role is pivotal because, as you said, serum sodium concentration is inversely proportional to total body water. meaning abnormalities in total body water often show up directly as abnormal serum sodium levels.
That's a critical principle to master in fluid and electrolyte management. Serum sodium concentration is indeed inversely proportional to total body water. This means any significant abnormality in TBW, whether it's too much or too little, will almost certainly manifest as an abnormality in serum sodium levels. It's a powerful, albeit indirect, indicator of fluid status.
Let's start with hyponatremia, which is a low serum sodium level, defined as less than 135 MEQL. This seems to be a common and potentially dangerous issue, especially in surgical patients.
It is, and it can be quite complex. Hyponatremia occurs when there's an excess of extracellular water relative to sodium. The interesting thing is that the extracellular fluid volume can be high, normal, or even low in these cases, which makes accurate diagnosis challenging. In most instances, the sodium concentration is decreased, either because of actual total body sodium depletion or because of dilution from excess free water.
Can you break down the causes into those specific categories, starting with dilutional hyponatremia?
Certainly. Dilutional hyponatremia, often associated with a high extracellular fluid volume or maybe euvolemia, usually means there's excess ECF water. This can be caused by excessive oral water intake or, quite commonly in a hospital setting, iatrogenic intravenous administration of too much free water, particularly hypotonic fluids like D5W. Postoperative patients are particularly susceptible to this because surgery itself can trigger increased secretion of ADH, antidiuretic hormone, which then increases the reabsorption of free water from the kidneys, leading to relative volume expansion and dilutional hyponatremia. Usually, this is a self-limiting response. However, various drugs like antipsychotics, tricyclic antidepressants, SSRIs, and ACE inhibitors can also cause water retention and subsequent hyponatremia. The elderly are particularly vulnerable to drug-induced hyponatremia. In these cases, physical signs of volume overload are often subtle or absent, and lab evaluation primarily shows hemodilution, where the blood components are diluted by excess water.
And then there's depletional hyponatremia, which sounds like a loss of sodium itself.
Yes. Depletional hyponatremia is associated with either a decreased intake or, more commonly in surgical patients, an increased loss of sodium-containing fluids. Here, a concomitant ECF volume deficit is common. Causes include a low-sodium diet or enteral feeds that are typically low in sodium. More often, it's due to significant GI losses from vomiting, prolonged nasogastric suctioning, profuse diarrhea, or high-output fistulas. Renal losses, perhaps from diuretic use, especially thiazide diuretics, or primary kidney disease that impairs sodium reabsorption can also lead to this. This is often accompanied by signs of hypovolemia.
I've also heard of hyponatremia in situations like uncontrolled diabetes or with certain osmotic agents. How do those fit into the picture?
That's an insightful question, and it represents a slightly different mechanism. Hyponatremia can also be seen when there's an excess of solute relative to free water in the plasma, such as with untreated hyperglycemia in diabetes or the therapeutic administration of mannitol. In these scenarios, the elevated glucose or mannitol acts as an osmotic agent, drawing water out of the cells and into the extracellular space. This influx of water dilutes the ECF sodium concentration, even though the total body sodium might be normal or even high. There's a useful calculation for this. For every 100 milligD increment in plasma glucose above normal, the plasma sodium should decrease by approximately 1.6 NaQL. Finally, a less common but important cause is pseudohyponatremia. This occurs with extreme elevations in plasma lipids, hyperlipidemia, and proteins, hyperproteinemia, like in multiple myeloma. Here, there's no true decrease in extracellular sodium relative to water. It's an artifact of how some laboratory methods measure sodium in a plasma sample heavily laden with fats or proteins, where the water content is proportionately reduced.
So if a patient has hyponatremia, what are the critical red flags we look for? What are the signs and symptoms, and why are the neurological ones so prominent?
The signs and symptoms depend heavily on the degree and, critically, the rapidity with which the hyponatremia developed. Rapid, severe drops in sodium are far more dangerous. The clinical manifestations primarily have a central nervous system origin, which is crucial for surgical patients. These are directly related to cellular water intoxication and the associated increases in intracranial pressure as water moves osmotically from the diluted extracellular fluid into the brain cells, causing them to swell. You might see headache, confusion, changes in deep tendon reflexes, nausea, vomiting, seizures, and in severe cases, stupor or coma. Oliguric renal failure can also be a rapid complication if the hyponatremia is severe and prolonged. These neurological symptoms underscore the immediate danger and the need for careful management.
How is hyponatremia typically diagnosed and differentiated in a systematic way, given its varied causes? This seems like a key point for mastery.
Diagnosis involves a systematic approach that the elite professional must master, absolutely. First, you carefully exclude hyperosmolar causes like hyperglycemia or mannitol infusion, and then rule out pseudo-hyponatremia based on serum lipid and protein levels. Once those are out, you evaluate the patient's extracellular volume status. Is it high, low, or normal? This clinical assessment of volume status, combined with urine sodium and urine osmolality, guides the differential. In the absence of primary renal disease, depletional hyponatremia due to sodium loss is associated with low urine sodium levels, typically less than 20 MEQL, as the kidneys try to conserve sodium. Renal sodium wasting, however, would show high urine sodium levels greater than 20 MEQL. Delusional causes of hyponatremia are usually associated with hypervolemic or euvolemic circulation. And if a patient has a normal volume status along with hyponatremia, that should immediately prompt an evaluation for syndrome of inappropriate secretion of antidiuretic hormone, or SIADH, as urine studies will show concentrated urine despite the low serum sodium.
Let's flip the coin and discuss hypernatremia. It's a high serum sodium level, defined as greater than 145 millieql. How does that typically occur, and what are its different presentations?
Hypernatremia, a state of water deficit relative to sodium, results from either a significant net loss of free water from the body or, less commonly, a gain of sodium in excess of water. Like hyponatremia, it can be associated with an increased, normal, or decreased extracellular volume, which requires careful clinical assessment.
So let's go through the causes again, starting with hypervolemic hypernatremia, where there's too much sodium and too much total body water.
Hypervolemic hypernatremia is relatively rare and is usually caused by iatrogenic administration of sodium-containing fluids, perhaps too much intravenous sodium bicarbonate during resuscitation, or hypertonic saline infused too rapidly. It can also stem from mineralocorticoid excess, seen in conditions like primary hyperaldosteronism or Cushing's syndrome, where the body retains excessive sodium and thus water. In these cases, the urine sodium concentration is typically high, greater than 20 mLUQL, and the urine osmolarity is also elevated, generally over 300 milliosmol, as the kidneys are trying to excrete the excess sodium and solute.
And then there's normovolemic hypernatremia, where the total body water and sodium are relatively balanced, but free water has been lost.
Correct. Normovolemic hypernatremia implies a pure water deficit. This can result from renal causes such as central or nephrogenic diabetes insipidus, certain diuretic use, or specific renal diseases that impair the kidney's ability to concentrate urine. It can also stem from non-renal pure water loss, such as excessive insensible losses from the GI tract, like severe vomiting of dilute stomach contents, or significant evaporation from the skin, like prolonged fever, extensive burns without appropriate fluid replacement. While these can also lead to hypovolemic hypernatremia, the distinction lies in the overall ECF volume status.
And what if the patient is hypovolemic along with being hypernatremic? This sounds like the double whammy.
In hypovolemic hypernatremia, which is quite common in surgical patients, there's a loss of both water and sodium, but the water loss is disproportionately greater than the sodium loss. Non-renal water loss is a common culprit. This can occur due to relatively isotonic GI fluid losses from profuse diarrhea or hypotonic skin fluid losses from a high fever causing excessive sweating. Even losses via tracheotomies during hyperventilation or conditions like thyrotoxicosis leading to increased metabolic rate and insensible losses, or the use of
So when do we typically see symptoms with hypernatremia, and what are those symptoms like? Why are they so dangerous?
Symptomatic hypernatremia usually only occurs in patients who have impaired thirst mechanisms or limited access to fluid. In most individuals, thirst would naturally prompt increased water intake to correct the imbalance. Symptoms are actually rare until the serum sodium concentration exceeds 160 millieql. However, once they appear, they are associated with significant morbidity and mortality, making rapid recognition crucial. Because the symptoms are directly related to hyperosmolarity, central nervous system effects predominate. Water shifts rapidly out of the brain cells into the hyperosmolar extracellular space, causing cellular dehydration and brain shrinkage. This can put severe traction on the cerebral vessels, potentially causing subarachnoid hemorrhage or subdural hematomas, which can be devastating. CNS symptoms can range from restlessness and irritability to tonic spasms, lethargy, delirium, seizures, coma, even death. You might also see the classic signs of hypovolemia, especially in hypovolemic hypernatremia, like tachycardia, orthostasis, and frank hypertension, along with unique findings specific to severe dehydration. Dry, sticky mucous membranes, a red swollen tongue, and decreased saliva and tears. Fever can also be present as a result of dehydration.
Beyond sodium, there are other critical electrolytes that can go awry. And their imbalances or composition changes can have profound effects on organ function, especially in a surgical context. Let's start with potassium, or K+ skills. Why is it so important, and how is its balance maintained?
Potassium is incredibly vital for almost every cellular function. The average dietary intake is about 50 to 100 millirq per day. And in a healthy person, the kidneys excrete most of it, typically ranging from 10 to 700 millirq per day, maintaining a tight balance through reabsorption and secretion. What's truly fascinating and clinically critical is that only about 2% of our total body potassium is found in the extracellular fluid. The vast majority, 98%, is concentrated inside our cells, largely due to the active work of the sodium-potassium pump. Yet this small extracellular amount is absolutely critical for cardiac and neuromuscular function. Even minor changes in ECF potassium can have major and immediate effects on heart rhythm and muscle excitability.
So let's talk about hyperkalemia. That's when serum potassium is above the normal range, usually considered 5-point or better QL. What causes this? And what are the precise warning signs we need to recognize immediately?
Hyperkalemia, often a medical emergency, can be caused by several mechanisms. Firstly, excessive potassium intake, such as from oral or IV supplementation, or from red cell lysis after a massive blood transfusion, can overwhelm the body's excretory capacity. Secondly, increased release of potassium from cells is a common cause, seen in conditions like hemolysis, red blood cell breakdown, rhabdomyolysis, muscle breakdown, crush injuries, or GI hemorrhage, where cell membranes are disrupted and intracellular potassium spills into the ECF. Conditions like acidosis, where hydrogen ions shift into cells, pushing potassium out, or a rapid rise in extracellular osmolality from hyperglycemia or IV mannitol can also cause potassium to shift out of cells. Because 98% of total body potassium is intracellular, even small shifts out of the cells can cause a clinically significant rise in extracellular potassium. Thirdly, impaired renal excretion is a major culprit, particularly in patients with acute or chronic renal insufficiency, where the kidneys cannot adequately excrete potassium. Certain medications, like potassium-sparing diuretics, spironolactone for example, ACE inhibitors, and NSAIDs, can also contribute by interfering with the kidney's normal potassium excretion mechanisms.
And the symptoms of hyperkalemia. What should clinicians be looking out for, especially the life-threatening ones?
The symptoms are primarily gastrointestinal, neuromuscular, and most critically cardiovascular. GI symptoms include nausea, vomiting, intestinal colic, and diarrhea. Neuromuscular symptoms can range from generalized weakness to ascending paralysis, even leading to life-threatening respiratory failure if the diaphragm is affected. But the most immediate and dangerous effects are cardiovascular, directly impacting myocardial excitability. Early signs are often apparent on an electrocardiogram, or ECG, and can rapidly progress to severe arrhythmias and cardiac arrest. Typical ECG changes include high, peak T waves, often the earliest sign, followed by a widened QRS complex, flattened or absent P waves, a prolonged PR interval leading to first-degree AV block, and in severe cases, the characteristic sine wave formation, followed by ventricular fibrillation and asystole. Rapid recognition of these ECG changes is paramount. They signal an impending cardiac catastrophe.
And the opposite end of the spectrum, hypokalemia, low serum potassium, defined as less than 3.5 ARGQL. You mentioned this is actually much more common in surgical patients. What are its causes, and what challenges does it present for clinicians?
Yes, hypokalemia is indeed much more common, especially in hospitalized surgical patients. Its causes are diverse. Inadequate potassium intake, such as from a dietary deficiency, prolonged administration of potassium-free IV fluids, or TPN, without adequate potassium supplementation, can lead to it. Excessive renal potassium excretion is another major cause. This can be due to conditions like primary or secondary hyperaldosteronism, or certain medications like loop diuretics, furosemide, amphotericin B, aminoglycosides, cisplatin, and ifosfamide. A crucial point here is that these medications often induce magnesium depletion, and hypokalemia due to magnesium depletion is very difficult, often impossible, to replete unless the hypomagnesemia is corrected first. Significant potassium loss also occurs with pathological GI secretions like from chronic diarrhea, high output fistulas, severe vomiting, or high nasogastric output. Finally, intracellular shifts can cause hypokalemia by temporarily moving potassium into cells even if total body stores are adequate. This is seen during metabolic alkalosis, where potassium shifts into cells in exchange for hydrogen ions, or during aggressive insulin therapy, which drives potassium into cells along with glucose.
There's a specific calculation for potassium changes in alkalosis, right? And you emphasize the critical link between potassium and magnesium.
There is a key clinical relationship. For every 0.1 increase in pH above normal due to alkalosis, serum potassium decreases by approximately 0.3 MEQL. This highlights the intimate connection between acid-base balance and potassium. And yes, the link between magnesium and potassium is absolutely critical for mastery. Hypokalemia that is refractory to potassium supplementation, meaning it just won't come up despite aggressive replacement, should always prompt a check for hypomagnesemia. Magnesium is a vital cofactor for the NA-K ATPase pump, and without adequate magnesium, the pump cannot function properly to maintain intracellular potassium, making effective potassium repletion impossible.
What are the clinical symptoms and ECG changes that should alert us to hypokalemia?
The symptoms of hypokalemia are primarily related to the failure of normal contractility of GI smooth muscle, skeletal muscle, and cardiac muscle, reflecting its role in membrane excitability. You might see ileus, paralysis of the bowel, severe constipation, generalized weakness, profound fatigue, diminished deep tendon reflexes, and even ascending paralysis that can lead to respiratory compromise. Of course, the most concerning are the cardiac effects, which can lead to life-threatening arrhythmias and cardiac arrest. Sometimes in the setting of ECF depletion, these symptoms might be masked initially, but then surprisingly worsen during volume repletion as dilution occurs. ECG changes suggestive of hypokalemia include the presence of prominent U waves, a positive deflection after the T-wave flattening or inversion, ST segment depression, and various arrhythmias. These are particularly concerning and potentially fatal if the patient is also on digitalis therapy.
Now let's move on to calcium, Ca2+ abnormalities. The vast majority of calcium is in our bones, but the small amount in the ECF is incredibly critical for vital functions. How do we measure it accurately, and how is its active form affected by other factors like albumin and pH?
That's a great question, and it's a common area of misinterpretation. Less than 1% of the body's total calcium is in the extracellular fluid, yet that small fraction is profoundly important for critical functions like neuromuscular stability, blood coagulation, and bone metabolism. Serum calcium exists in three forms. About 40% is protein-bound, primarily to albumin, 10% is complex to anions like phosphate or citrate, and a crucial 50% is the ionized fraction. It's this ionized calcium that is physiologically active and directly responsible for neuromuscular stability and other cellular functions.
So if a patient has low albumin, their total calcium might appear low, but their active ionized calcium could be normal. How do clinicians account for this?
Exactly. This is a common pitfall in interpreting calcium levels. When total serum calcium levels are measured, you must take the albumin concentration into consideration, as hypoalbuminemia will falsely lower the total calcium reading. As a rule of thumb, you should adjust the total serum calcium downward by 0.8 milligdl for every 1 GDL decrease in serum albumin below normal. So a seemingly low total calcium might not signify true hypocalcemia if the albumin is also low. In contrast to albumin, changes in pH directly affect the ionized calcium concentration. Acidosis decreases protein binding of calcium, which means it increases the ionized fraction, even if total calcium is unchanged. Conversely, alkalosis increases protein binding, which decreases ionized calcium. This is why a patient can develop symptoms of hypocalcemia like tetany, even with a normal total calcium if they become acutely alkalotic, perhaps from hyperventilation.
What are the primary causes and symptoms of hypercalcemia, defined as total serum calcium greater than 10.5 mEqL or ionized calcium greater than 4.8 milligdl? What makes this particularly dangerous in surgical patients?
Hypercalcemia, when symptomatic, is a serious condition. In outpatients, the most common cause is primary hyperparathyroidism. However, in hospitalized surgical patients, malignancy is the predominant cause, often from widespread bony metastasis, like from breast or renal cell cancer, or the secretion of parathyroid hormone-related protein, PTHrP, by tumors. The symptoms are often nonspecific but vary with severity and can impact multiple organ systems. Neurologically, you might see impairment, confusion, lethargy, even coma. Musculoskeletal symptoms include generalized weakness and pain, often described as bone aches. Renal dysfunction can manifest as polyuria, excessive urination, and polydipsia, excessive thirst, and can lead to kidney stones in chronic cases. GI symptoms include anorexia, nausea, vomiting, constipation, and vague abdominal pain. Cardiovascularly, hypertension, various arrhythmias, and worsening digitalis toxicity are possible. On the ECG, you might observe a characteristic shortened QT interval, prolonged PR and QRS intervals, increased QRS voltage, T-wave flattening or widening, and potentially AV block progressing to complete heart block and even cardiac arrest. The mnemonic stones, bones, groans, and psychiatric overtones often helps remember the symptoms.
And the opposite, hypocalcemia, defined as total serum calcium less than 8.5 MEqL, or ionized calcium less than 4.2 mg/dL. That can also be quite dangerous. What are its surgical causes?
Hypocalcemia, particularly when it impacts the ionized fraction, is a serious concern. Its causes are diverse and often very relevant in surgical contexts. Acute pancreatitis can cause it due to chelation of calcium with free fatty acids released during fat necrosis, as can massive soft tissue infections like necrotizing fasciitis. Renal failure with impaired phosphate excretion frequently leads to hyperphosphatemia, which in turn causes calcium precipitation and hypocalcemia. Pancreatic and small bowel fistulas can also result in significant calcium loss. Hypoparathyroidism, whether congenital or, more commonly in surgery, acquired due to accidental parathyroid gland injury or removal during neck surgery, like thyroidectomy, leads to insufficient PTH secretion. Toxic shock syndrome, certain magnesium abnormalities, and tumor lysis syndrome, due to massive phosphate release, are also culprits. A transient but significant hypocalcemia, known as hungry bone syndrome, often occurs days to weeks after removal of a parathyroid adenoma due to rapid, avid burn remineralization that draws calcium out of the serum. Malignancies with increased osteoblastic activity, such as metastatic breast and prostate cancer, can also paradoxically lead to hypocalcemia by drawing calcium into new bone formation. Lastly, massive blood transfusion can cause it due to citrate, an anticoagulant in blood products binding to calcium. It rarely results solely from decreased dietary intake, as bone reabsorption compensates for a long time.
What are the precise clinical signs that make you strongly suspect hypocalcemia? What are the red flags?
The clinical presentation can vary. Asymptomatic hypocalcemia can occur when hypoproteinemia results in a normal ionized calcium level, as we discussed. Conversely, symptoms can develop with a normal total serum calcium level during acute alkalosis, as this decreases the ionized calcium fraction. In general, significant neuromuscular and cardiac symptoms occur when the ionized fraction falls below 2.5 mg/dL. Clinically, you might observe paresthesias, particularly tingling around the mouth and in the fingers and toes, muscle cramps, carpal spasm, involuntary contraction of hand-foot muscles, laryngeal stridor, a high-pitched breath sound due to airway obstruction, frank tetany, and even generalized seizures. Patients often exhibit hyperreflexia. Classic physical signs include a positive Scherzostak sign, that facial muscle spasm elicited by tapping over the fascial nerve, and Trousseau's sign, carpal spasm, induced by inflating a blood pressure cuff. It can also lead to decreased cardiac contractility and heart failure. ECG changes of hypocalcemia include a characteristic prolonged QT interval, T-wave inversion, various heart blocks, and ventricular fibrillation, all of which can be life-threatening.
Moving on to phosphorus P abnormalities. This is another electrolyte that's primarily intracellular and crucial for energy. How do its levels get disrupted, and what are the consequences?
Phosphorus, or phosphate, is indeed a primary intracellular divalent anion, second only to potassium in intracellular concentration. It's highly abundant in metabolically active cells and is absolutely crucial for energy production, particularly as a component of ATP. Its serum levels are tightly controlled, primarily through precise renal excretion and reabsorption, influenced by parathyroid hormone, vitamin D, and FGF23.
So with hyperphosphatemia, defined as serum phosphorus greater than 4.5 mg/dL, what are the common causes in surgical patients?
Hyperphosphatemia can be caused by several mechanisms. Firstly, decreased urinary excretion is the most common cause, seen primarily in patients with impaired renal function, but also with hypoparathyroidism or hyperthyroidism. Secondly, increased intake, such as from aggressive 5E hyperalimentation solutions or phosphorus-containing laxatives, can acutely elevate levels. Thirdly, endogenous mobilization of phosphorus, where it's rapidly released from cells, occurs in any condition causing massive cell destruction. Think rhabdomyolysis, tumor lysis syndrome, massive hemolysis, severe sepsis, severe hypothermia, and malignant hyperthermia. Most cases of hyperphosphatemia are asymptomatic acutely, but prolonged and significant hyperphosphatemia can lead to metastatic deposition of soft tissue calcium phosphorus complexes, particularly in the kidneys, joints, and arteries, causing long-term problems.
And what about the opposite, hypophosphatemia, where serum phosphorus is less than 2.5 mg/dL? This often goes unnoticed until it's severe.
Hypophosphatemia can result from several factors. Firstly, a decrease in phosphorus intake or GI uptake, perhaps due to chronic malabsorption syndromes, prolonged use of phosphate binders like aluminum hydroxide antacids, or severe malnutrition. Secondly, and very acutely, it can be caused by a rapid intracellular shift of phosphorus. This can be triggered by respiratory alkalosis, insulin therapy, refeeding syndrome, where starved cells rapidly take up phosphate for metabolism, or hungry bone syndrome, post-parathyroidectomy. Thirdly, an increase in renal excretion can also lead to hypophosphatemia. Clinical manifestations usually don't appear until levels fall significantly, typically below 1.0 mg/dL, and when they do, they're related to adverse effects on tissue oxygen availability due to decreased 203 bpg in red blood cells and a decrease in high-energy phosphates like ATP. This can present as severe cardiac dysfunction, generalized muscle weakness, and respiratory failure due to diaphragmatic weakness.
Finally, let's discuss magnesium, Mg2 plus abnormalities. It's the fourth most common mineral in the body, but similar to potassium, most of it is inside the cells. How does this make it challenging to assess, and why is it so crucial for many other electrolyte balances?
It's true, magnesium is primarily intracellular, about half of its total body content stored in bone and much of the rest within cells. Of the small fraction in the extracellular space, approximately 1/3 is bound to serum albumin. This means that if a patient has hypoalbuminemia, their plasma magnesium level can be a poor indicator of their true total body magnesium stores, necessitating careful clinical correlation. The kidneys are remarkably efficient at consuming magnesium, typically excreting less than 1 millicu per day during states of magnesium deficiency. Magnesium is a critical cofactor for over 300 enzyme systems, playing a vital role in ATP metabolism, protein and nucleic acid synthesis, and crucially in maintaining the function of the sodium-potassium pump. This last point explains its profound importance for potassium and calcium homeostasis.
So when do we see hypermagnesemia, defined as serum magnesium greater than 2.5 milli-UQL? Sounds relatively rare, but potentially quite serious.
It is relatively rare, but can be life-threatening. Hypermagnesemia is most commonly seen with severe renal insufficiency, often paralleling changes in potassium excretion as both are renally cleared. Patients with renal failure who inadvertently take magnesium-containing antacids or laxatives are at high risk. Excess intake from aggressive TPN or parenteral magnesium administration, or rarely, conditions like massive trauma, extensive thermal injury, burns, or severe acidosis can lead to symptomatic hypermagnesemia. Clinically, the symptoms are dose-dependent, but you might see nausea, vomiting, followed by neuromuscular dysfunction characterized by profound weakness, lethargy, and hyperflexia, diminished deep tendon reflexes. Importantly, it can cause impaired cardiac conduction leading to hypotension, bradycardia, and even cardiac arrest. ECG changes are similar to hyperkalemia, increased PR interval, a widened QRS complex, and elevated T waves. These signs demand immediate attention.
And hypomagnesemia, where serum magnesium is less than 1.5 milli-EQL. This seems to be much more common in hospitalized and critically ill patients.
Yes, magnesium depletion is indeed a common and often under-recognized problem, especially in hospitalized and critically ill patients. The kidneys are the primary regulators of magnesium homeostasis via calcium-magnesium receptors on renal tubular cells. Hypomagnesemia can result from several factors. Firstly, poor intake due to starvation, chronic alcoholism, prolonged IV fluid therapy without adequate supplementation, or inadequate TPN supplementation. Secondly, increased renal excretion can occur with chronic alcohol abuse, diuretic use, especially loop and thiazide diuretics, or administration of drugs like amphotericin B, aminoglycosides, cisplatin, and in conditions like primary aldosteronism. Finally, significant GI losses from chronic diarrhea, malabsorption syndromes, or acute pancreatitis can also cause it.
And the symptoms. Do they mirror calcium deficiency because of that vital connection you mentioned?
They do, quite remarkably. Because magnesium is essential for many enzyme systems, its depletion leads to widespread neuromuscular and central nervous system hyperactivity. Symptoms often mirror those of calcium deficiency, including hyperactive reflexes, muscle tremors, profound weakness, tetany, involuntary muscle spasms, and positive Chvostek's and Trousseau's signs. Severe deficiencies can progress to delirium, disorientation, and even seizures. ECG changes are also significant. Prolonged QT and PR intervals, ST segment depression, flattening or inversion of P waves, and critically polymorphic ventricular tachycardia, specifically torsades of point, and other life-threatening arrhythmias. The clinical significance of hypomagnesemia extends beyond its direct effects. It's important not only for its own sake, but also because it can induce hypocalcemia by impairing PTH release and receptor response, and lead to persistent refractory hypokalemia by impairing the NAK-AT pump. When hypokalemia or hypocalcemia coexist with hypomagnesemia, magnesium should be aggressively replaced first, as it is often essential to help restore potassium or calcium homeostasis.
Okay, so with all these potential imbalances, the next crucial step is understanding how we restore balance. Let's talk about the IV arsenal, the parenteral solutions that are used to precisely correct these abnormalities.
This is truly where theory meets precise clinical practice. The type of intravenous fluid administered is entirely dependent on the patient's estimated volume status and the specific concentration or compositional abnormality present. Among the most commonly used solutions are what we call isotonic solutions, meaning they have an osmolality similar to plasma. These include Plasma-Lyte, lactated ringers, and normal saline. These are incredibly useful for replacing gastrointestinal losses, expanding the extracellular fluid, and correcting ECF volume deficits.
What are the key differences between lactated ringers and normal saline? They seem to be used interchangeably sometimes, but they have very distinct properties that elite professionals must understand.
They do, and the distinctions are profoundly important for patient outcomes. Lactated ringers, LR, is slightly hypertonic relative to plasma, containing 130 millionec of sodium per liter, along with lactate, potassium, calcium, and chloride. The lactate is crucial because it converts to bicarbonate in the liver, even in states of hemorrhagic shock, providing a buffering effect. And it's more stable in IV fluids during storage than actual bicarbonate. This makes LR a popular choice for broad resuscitation, as it resembles the ECF more closely than normal saline. 0.9% sodium chloride, or normal saline, NS, on the other hand, is considered isotonic, containing 154 millieq of both sodium and chloride. While widely used, its relatively high chloride concentration compared to plasma can impose a significant chloride load on the kidneys, potentially leading to a hyperchloremic metabolic acidosis, especially with large volumes. However, it is an ideal solution for correcting volume deficits, specifically when they are associated with hyponatremia, hypochloremia, and metabolic alkalosis because of that high sodium and chloride content, which can help correct the underlying issues.
And Plasma-Lyte, you mentioned, it's quite popular now. What makes it a preferred choice for some?
Yes, Plasma-Lyte is a crystalloid preparation that is carefully formulated to most closely resemble the electrolyte composition of human plasma. Beyond its favorable isotonic electrolyte profile, it contains acetate and gluconate, which are additional buffers that help address acidosis. These characteristics have made Plasma-Lyte a very popular choice for isotonic fluid resuscitation in surgery and critical care. One important thing to note is that it contains small quantities of potassium, 5 millieql. So while the risk of inducing hyperkalemia is very low in most patients, care should be taken with patients at risk for severe renal impairment.
And what about the less concentrated sodium solutions or dextrose solutions? When are those appropriate?
Less concentrated sodium solutions, such as 0.45% sodium chloride, half normal saline, are hypertonic relative to plasma. They are useful for replacing ongoing GI losses that are hypotonic and for maintenance fluid therapy in the postoperative period when free water is needed to compensate for insensible losses. This solution provides enough free water for insensible losses and sufficient sodium for the kidneys to adjust for concentration. Dextrose solutions, primarily 5% dextrose in water, D5W, provide about 200 kilocals per liter, offering minimal caloric support but primarily serving as a source of free water. Dextrose is almost always added to solutions containing less than 0.45% sodium chloride to maintain osmolality and prevent the lysis of red blood cells that could occur from rapid infusion of pure hypotonic fluids directly into the bloodstream. Once renal function and adequate urine output are established, potassium can then be safely added to these IV fluids to prevent hypokalemia.
Beyond these standard IV solutions, there's been a lot of debate about alternative resuscitative fluids, like hypertonic saline and colloids. What does the current evidence, specifically from large clinical trials, say about their role, especially in surgical patients?
This is a continuously evolving and often debated area in critical care and surgery. Hypertonic saline solutions, typically 3.5%, 5%, or 7.5%, are primarily used for correcting severe symptomatic sodium deficits where a rapid, controlled increase in serum sodium is required. The 7.5% solution specifically has been investigated for use in patients with severe closed head injuries. The rationale is that its high osmolality would draw water out of edematous brain cells, thereby increasing cerebral perfusion and decreasing intracranial pressure, effectively reducing brain edema. However, there have been concerns about potential side effects, including increased bleeding due to its effect as an arteriolar vasodilator. Recent meta-analyses, including one on severe traumatic brain injury that reviewed 11 studies, consistently showed no mortality benefit for hypertonic saline compared to other isotonic solutions.
And what about colloid substances like albumin, dextrins, hitostarch, and gelatins? There's been a long-standing and often passionate debate about their effectiveness compared to isotonic crystalloids for resuscitation. What's the current consensus?
Indeed, the debate has been extensive, but the evidence base has become much clearer. Colloids, due to their high molecular weight, are theoretically largely confined to the intravascular space, which means they are more efficient at providing rapid, transient plasma volume expansion per unit volume infused. However, in situations like severe hemorrhagic shock or sepsis, where there's increased capillary permeability, often referred to as capillary leak, colloids can actually leak into the interstitial space. When this happens, they can paradoxically worsen interstitial edema and potentially impair tissue oxygenation, which defeats their purpose and can lead to organ dysfunction, particularly lung injury.
So, what do the major clinical trials and systematic reviews, which guide professional practice, tell us definitively about colloids?
The evidence has largely solidified against their widespread use for routine resuscitation. The Crystal randomized trial, a large multi-center study that looked at critically ill patients with hypovolemic shock, found no improvement in 30-day mortality for colloids versus crystalloids. While there was an exploratory suggestion of 90-day mortality improvement and more days alive without mechanical ventilation with colloids, these were not primary endpoints and require further rigorous investigation. A comprehensive Cochrane database systematic review, which analyzed 70 trials, concluded that there's simply no evidence to support colloid use over crystalloid to reduce death in trauma, burns, or general surgery. Furthermore, specific colloids like hydroxyethyl starch, HES, have actually been associated with increased morbidity. A large randomized trial showed no mortality benefit over saline, but a statistically significant increase in the need for renal replacement therapy after HES use.
So, given all that evidence, the overall conclusion seems pretty clear then for routine surgical patient resuscitation.
The current professional consensus, based on robust evidence, is that colloids are markedly more expensive than crystalloids. And given the data, their use in the routine resuscitation of critically ill and surgical patients has very limited application. Crystalloids remain the standard of care for initial volume resuscitation.
Now let's get into the nitty-gritty. Correction of life-threatening electrolyte abnormalities. This is where precise, targeted interventions are crucial to prevent severe morbidity and mortality. Let's start with sodium. How do we approach the treatment of hypernatremia, which signifies a significant water deficit?
For hypernatremia, treatment primarily consists of carefully addressing the associated free water deficit. In hypovolemic patients, the absolute first step is to restore their circulating volume with isotonic fluids, typically normal saline, before you even attempt to correct the concentration abnormality. This ensures adequate organ perfusion. Once adequate volume has been achieved, then the calculated water deficit is replaced using a hypertonic fluid. Things like 5% dextrose in water, D5W, 5% dextrose in 0.25% normal saline, or even just enterally administered water if the patient can tolerate it.
And there's a precise formula for calculating that water deficit, correct? And what are the critical rates of correction to prevent complications?
Yes, there is. The formula to estimate the total water deficit is water deficit L, serum sodium 140, total body water TBW. For estimating TBW, you typically use 50% of lean body mass in men and 40% in women. The correction rate is incredibly important and cannot be overemphasized. You should decrease serum sodium by no more than 1 millicor and a maximum of 12 millicor for acute symptomatic hypernatremia. For chronic hypernatremia, where the brain has had time to adapt, the correction should be even slower, at approximately 0.7 millicor to allow the brain to re-equilibrate safely.
What are the dangers of correcting hypernatremia too quickly, and how do you monitor for that?
Overly rapid correction of hypernatremia is extremely dangerous. It can lead to severe complications such as cerebral edema and subsequent brain herniation, which can be devastating and fatal. For this reason, frequent neurological evaluations and frequent serial monitoring of serum sodium levels, like every 2 to 4 hours initially, are absolutely mandatory during this entire correction process. Although less common than hypernatremia carries a worse prognosis and is an independent predictor of mortality and critical illness, underscoring the need for meticulous management.
So what about hyponatremia correction, especially when it's severe and symptomatic, given its neurological risks?
For mild asymptomatic hyponatremia, simply restricting free water intake might be enough. But for symptomatic hyponatremia, particularly when serum sodium is 120 milliQL or less and accompanied by severe neurological symptoms like seizures or coma, you must use hypertonic saline, typically 3% normal saline. The goal is to increase serum sodium by no more than 1 LAQL per hour until the serum sodium reaches 130 milliQL or the neurological symptoms significantly improve. For asymptomatic hyponatremia, the correction rate should be even slower, no more than 0.5 milliQL per hour with a maximum increase of 12 milliQL per day. This rate should be even slower, perhaps 8 millieql per day for chronic cases where the brain has more thoroughly adapted to the low sodium.
And just like with hypernatremia, rapid correction here has its own set of very dangerous consequences that professionals must meticulously avoid.
Absolutely. The rapid correction of hyponatremia, particularly chronic hyponatremia, can lead to osmotic demyelination syndrome, most notably pontine myelinolysis. This is a severe neurological disorder characterized by irreversible damage to the myelin sheath of nerve cells, especially in the pons. Clinically, it presents with seizures, weakness, paresis, partial paralysis, akinetic movements, unresponsiveness, permanent brain damage, and even death. Serial magnetic resonance imaging, MRI, may be necessary to confirm the diagnosis. The key takeaway for any elite professional is that slow, controlled, and carefully monitored correction is paramount to avoid these life-threatening and often irreversible complications.
Now for potassium correction. Hyperkalemia, given its direct cardiac risks, requires immediate and decisive action. What are the multifaceted treatment goals and specific strategies to achieve them?
The goals for treating symptomatic hyperkalemia are threefold and often require simultaneous intervention. First, to reduce the total body potassium. Second, to rapidly shift potassium from the extracellular space back into the intracellular space, a temporary measure. And third, to immediately protect the cells, especially cardiac cells, from the immediate toxic effects of increased extracellular potassium.
Okay. So how do we reduce total body potassium and shift it into cells, both short-term and long-term?
First, you must immediately remove all exogenous sources of potassium, like potassium supplementation from IV fluids, enteral feeds, or parenteral nutrition solutions. To physically remove potassium from the body over a longer term, we use cation exchange resins like Electrolyte, sodium polystyrene sulfonate, which binds potassium in the GI tract in exchange for sodium. It can be given orally, 15-30 grams in 50-100 milliliter 20% sorbitol, or rectally, 50 grams in 200 milliliters 20% sorbitol enema. For a rapid temporary shift of potassium into cells, which typically lasts about 1 to 4 hours, immediate measures include giving intravenous glucose, typically 1 ampule of D50 or 25G, along with regular insulin, 5-10 units 4. While glucose alone might stimulate insulin in acutely ill patients, that endogenous insulin response can be blunted, so both insulin and glucose are often necessary. Nebulized albuterol, 10 to 20 milligrams, can also be used as it stimulates beta-2 receptors, which drive potassium into cells. A word of caution. Kioxalate and high-sodium solutions can cause circulatory overload and hypernatremia, so use them carefully in patients with fragile cardiac function.
And to specifically protect the heart from potassium's immediate toxic effects.
If ECG changes are present, indicating a direct threat to myocardial excitability, that's an immediate life-threatening emergency. Calcium chloride or calcium gluconate, typically 5-10 milliliters of 10% solution, should be administered intravenously immediately to rapidly stabilize cardiac cell membranes and counteract the myocardial effects of hyperkalemia. Calcium chloride acts faster and delivers more calcium per unit. However, exercise extreme caution if the patient is on digitalis, as calcium infusion can precipitate digitalis toxicity. Remember, all these measures, glucose insulin, albuterol, calcium, are temporary fixes that buy time. If hyperkalemia is severe and refractory to conservative measures, or if there's underlying renal failure, hemodialysis is the definitive last resort and should be considered without delay.
On the other side, hypokalemia treatment depends heavily on the patient's symptoms and the severity of the deficit. What are the guidelines for repletion?
Absolutely. The repletion strategy for hypokalemia is carefully titrated to the patient's clinical status. For mild asymptomatic hypokalemia, like K plus 3.0, 3.5 MEQL, oral repletion, often with KCl tablets, say 20-40 MEQL, is usually sufficient. If intravenous repletion is required due to symptoms, for example, K plus 3.0 MEQL or with ECG changes, the rate is crucial to prevent rapid swings and complications. In an unmonitored setting, generally no more than 10 millicor potassium chloride is advisable. However, with continuous ECG monitoring and close observation, you can go up to 20-40 millicor in severe cases. In situations of imminent cardiac arrest due to a malignant arrhythmia, like torsades de pointes in the setting of hypokalemia, even higher rates may be necessary under direct physician supervision. Always exercise extreme caution if the patient has oliguria or impaired renal function, as potassium excretion will be compromised, leading to a risk of iatrogenic hyperkalemia.
Let's move to calcium correction. When is treatment for hypercalcemia required, and what's the initial physiological approach?
Treatment for hypercalcemia is required when the patient is symptomatic, which usually occurs when serum levels exceed 12 mg/dL. The critical level is 15 mg/dL, where symptoms can rapidly progress to life-threatening complications. The initial and often most effective treatment aims to correct any associated volume deficit by administering large volumes of normal saline. This saline volume expansion directly decreases renal reabsorption of calcium. Once adequate volume is achieved, the next step is often to induce a brisk diuresis using a loop diuretic like furosemide, which further enhances renal calcium excretion. However, it's vital to ensure the patient is euvolemic before administering loop diuretics, as they can worsen hypovolemia. Treatment for malignancy-associated hypercalcemia involves more specific interventions we'll detail shortly.
And for hypocalcemia, that can be equally dangerous.
For asymptomatic hypocalcemia, where ionized calcium is normal despite low total calcium, maybe due to hypoalbuminemia, oral calcium supplementation is typically sufficient. However, acute symptomatic hypocalcemia, particularly when ionized calcium is low and symptoms like tetany or seizures are present, requires immediate intervention with intravenous 10% calcium gluconate, usually administered slowly to achieve a serum concentration of 7 to 9 mg/dL. Calcium chloride can also be used, but is more irritating to veins. It's vital to correct any associated magnesium, potassium, and pH deficits, because hypocalcemia will be refractory to treatment if coexisting hypomagnesemia is not corrected first, and alkalosis will worsen symptoms by reducing ionized calcium. It's also important to note that routine calcium supplementation is generally no longer recommended with massive blood transfusions unless signs of hypocalcemia are specifically observed due to the transient nature of citrate binding.
So on to phosphorus correction. How do we manage hyperphosphatemia, and what's the primary goal?
For hyperphosphatemia, the primary goal is to decrease phosphorus levels. Phosphate binders, such as sucralfate or aluminum-containing antacids, can be used. These are given with meals to bind dietary phosphate in the gut, preventing its absorption. Calcium acetate tablets are also useful as binders, especially if the patient concurrently has hypocalcemia. For severe cases, particularly in patients with renal failure where phosphorus excretion is severely compromised, dialysis is typically required to remove excess phosphate from the body.
And for hypophosphatemia, especially when it's severe and symptomatic?
Treatment for hypophosphatemia involves various enteral or parenteral repletion strategies, depending on the level of depletion and the patient's tolerance for oral intake. For example, Nutriphos packets can be used for enteral repletion in mild to moderate cases. Intravenous options include KPHO4, potassium phosphate, or NEPO4, sodium phosphate. Dosages typically range from 0.15 to 0.25 millimole per kilogram of lean body weight over several hours. It's crucial to consider the patient's renal function when determining the dosage and route, as rapid 5E repletion in a patient with impaired renal function can quickly lead to hyperphosphatemia.
Finally, magnesium correction. How do we address hypermagnesemia, given its rarity but potential severity?
For hypermagnesemia, the initial steps involve correcting any concurrent volume deficits and acidosis. For immediate antagonism of potentially life-threatening cardiovascular effects, intravenous calcium chloride, 5-10 millimounts of 10% solution, should be administered rapidly. This stabilizes cardiac membranes. If elevated levels or symptoms persist, particularly in the setting of renal failure, hemodialysis may be necessary to remove excess magnesium from the body.
And hypomagnesemia. This is so common in hospitalized and critically ill patients.
For hypomagnesemia, oral repletion is suitable for asymptomatic and mild cases. However, intravenous repletion is clearly indicated for more severe or symptomatic deficiencies. For severe deficits, defined as less than 1.0 mEqL, or for symptomatic patients, like with arrhythmias or tetany, 1 to 2 grams of magnesium sulfate can be administered intravenously over 15 minutes. In acute, life-threatening situations like torsades de pointe, specific irregular heart rhythm, it might even be given more rapidly, over 2 minutes, but always under continuous ECG monitoring due to the risk of inducing hypermagnesemia. A crucial caution here is magnesium toxicity, which can develop with rapid administration, leading to hypotension or respiratory depression. Simultaneously administering calcium gluconate can help counteract the adverse side effects of a rapidly rising magnesium level and also correct any associated hypocalcemia, which is frequently coexistent with hypomagnesemia.
All right, let's talk about preoperative fluid therapy. This is the vital phase where we prepare the patient for the physiological demands of surgery. For a healthy individual who's fasting, what's the baseline fluid requirement and how is it calculated with precision?
For an otherwise healthy individual who's simply fasting, or NPO and nothing by mouth, maintenance fluids are all that's typically required to replace normal daily losses. We use a precise formula to estimate this. For the first 10 kilogram of body weight, you calculate 100 millekilojule. For the next 20 kilograms, you add an additional 50 millekilojule. And for any body weight above 20 kilograms, you add another 20 millekilojule. So for example, a 60 kilogram female would need 10 kilograms 100 plus, 10 kilograms 50 plus 40 kilograms 20 plus 500 plus 800 plus 2300 milliliters per day, roughly. An alternative, often used in practice, is to simply replace estimated daily water losses with a hypertonic saline solution, such as 5% dextrose and 0.45% sodium chloride. Typically administered at a rate of approximately 100 milliliter for adults, adding potassium once renal function is confirmed as normal.
But many surgical patients aren't otherwise healthy at baseline, are they? They often come in with existing deficits, and addressing these preoperatively is a critical component of successful surgery.
That's the real clinical challenge and a point of mastery. Many surgical patients indeed present with significant volume and/or electrolyte abnormalities due to their underlying surgical disease, whether it's an obstruction, infection, or trauma. Preoperative evaluation of these deficits is absolutely critical. Volume deficits should always be considered in patients with obvious GI losses like chronic emesis, profuse diarrhea, or high-output ostomies, or those with prolonged poor oral intake. However, less obvious but profoundly significant are third space losses or non-functional ECF losses. This is fluid that ships out of the functional extracellular space into areas where it's not readily available to the circulation, such as fluid trapped in the lumen of a distended bowel with GI obstruction, fluid accumulating in the peritoneal cavity due to peritonitis, severe inflammation, ascites, extensive crush injuries, large burns, or severe soft tissue infections like necrotizing fasciitis. This sequestered fluid is functionally lost from the active circulation.
How precisely do you diagnose an acute volume deficit preoperatively, and how aggressively should it be corrected to optimize the patient for surgery?
Diagnosis of an acute volume deficit is primarily clinical, requiring a keen eye for subtle signs. While physical signs vary with the duration and severity of the deficit, cardiovascular signs like tachycardia and orthostasis, usually accompanied by oliguria, reduced urine output, typically 0.5 millicone curie jar, and hemoconcentration, are key indicators of acute significant loss. It's crucial to correct these acute volume deficits as completely as possible before the operation begins, as uncorrected hypovolemia significantly increases intraoperative and postoperative risks. Prompt fluid replacement, usually with an isotonic crystalloid solution, should be instituted immediately. Patients with clear cardiovascular signs of deficit should receive a rapid bolus of 1 to 2 liters of isotonic fluid, followed by a continuous infusion. Monitoring is imperative, guided by the reversal of these deficit signs. Stable vital signs, adequate urine output, 0.51 millicurie hour, and correction of metabolic acidosis as reflected by a normalized base deficit or lactate level. For complex patients, those not responding to initial fluid challenges, or the elderly with limited physiological reserve, more intensive hemodynamic monitoring in an ICU might be necessary, including central venous pressure or cardiac output monitoring.
And what if there are symptomatic electrolyte abnormalities, particularly life-threatening ones, along with the volume deficit? Should those be completely corrected before surgery?
That's a critical decision point. If symptomatic electrolyte abnormalities accompany the volume deficit, the abnormality should be corrected to the point that acute symptoms are relieved before surgical intervention, if at all possible. For instance, with severe hypernatremia and a volume deficit, you want to avoid a rapid, unsafe fall in extracellular osmolarity during correction. So instead of just 5% dextrose, you carefully and slowly correct the hypernatremia with hypotonic saline, such as 0.45% saline, or even lactated Ringer's solution, which is slightly hypotonic relative to saline. This strategy safely and slowly corrects the hypernatremia while simultaneously addressing the associated volume deficit, preparing the patient optimally for the stress of surgery.
All right, so we've meticulously prepared the patient. Now let's move into the operating room for intraoperative fluid therapy. What happens during surgery itself, and how does anesthesia specifically impact the patient's fluid balance and the approach to management?
During the induction of anesthesia, the body's natural compensatory mechanisms, like sympathetic nervous system tone, are often blunted or lost. If preoperative volume deficits haven't been adequately corrected, this loss of compensatory vasoconstriction can quickly lead to profound hypotension, which compromises organ perfusion. The overarching goal during surgery is to maintain hemodynamic stability by correcting any known preoperative losses, replacing ongoing intraoperative losses, and providing adequate maintenance fluid therapy to meet baseline needs.
And what exactly are these ongoing losses during surgery? It's more complex than just visible blood loss, isn't it?
Much more complex, and this is a subtle area that demands mastery. Beyond directly measured blood loss from the surgical field, major open abdominal surgeries, for example, are associated with significant continued extracellular losses in the form of bowel wall edema, accumulation of peritoneal fluid, and wound edema. Similarly, large soft tissue wounds, complex fractures, and extensive burns also cause substantial third space losses. These are considered distributional shifts or parasitic losses because the functional volume of the extracellular fluid is reduced. It's essentially trapped in non-functional interstitial spaces. But the fluid isn't externally lost from the body. It's a challenge to quantify, but it needs to be replaced.
I understand that the approach to intraoperative fluids has actually changed quite a bit over the years based on pivotal research. What's the historical context here, and how did our understanding evolve?
Indeed. It's a fascinating and important historical shift in surgical practice. Until the 1960s, saline solutions were actually largely withheld during surgery. It was believed by some that administered saline would be retained and was an inappropriate challenge to a perceived physiological response of intraoperative salt intolerance, believing it would worsen edema. However, pioneering basic and clinical research, most notably by Shires and colleagues in the 1960s, fundamentally changed this concept. Their seminal work rigorously demonstrated that saline administration is necessary to restore those obligate ECF losses that occurred during surgery due to capillary leak and third spacing. While there's still no single, perfectly accurate formula to predict exact intraoperative fluid needs for every patient, current practice often requires 500 to 1,000 millimolars per hour of a balanced salt solution, like lactated ringers or Plasmolite, to support fluid homeostasis during major surgery. This shift represented a major advance in reducing surgical morbidity.
And what about colloids intraoperatively? Do they have a role there, or does the evidence base, as we discussed earlier, still hold true?
Despite the historical debate and theoretical advantages, the addition of albumin or other colloid-containing solutions to intraoperative fluid therapy is generally not considered necessary for routine major surgery. Studies, including a significant one looking at albumin infusion during major vascular surgery, showed no definitive advantage in supporting cardiac function or preventing the accumulation of extravascular lung water, pulmonary edema, compared to crystalloids. The evidence continues to point towards balanced crystalloids as the primary and preferred choice for intraoperative volume management due to their efficacy, safety, and lower cost.
So we've navigated the preoperative preparation and intraoperative challenges. Now let's look at postoperative fluid therapy. What's the comprehensive approach once the surgery is done and the patient is in the critical recovery phase?
Postoperative fluid therapy needs to be meticulously tailored based on the patient's current estimated volume status and any projected ongoing fluid losses. You essentially need to correct any deficits that may have accumulated preoperatively or intraoperatively, while also accounting for ongoing maintenance requirements and replacing specific measured losses. Those third space losses, while often difficult to measure precisely, still need to be considered and included in fluid replacement strategies as they gradually re-equilibrate back into the functional ECF over several days post-op.
What kind of fluid is typically given initially after surgery, and how do you assess if enough fluid has been given to ensure adequate resuscitation?
In the initial postoperative period, an isotonic solution is typically administered, such as lactated ringers or Plasmolite, to continue addressing volume needs. The adequacy of resuscitation is primarily guided by the restoration of acceptable vital signs, heart rate, blood pressure, mean arterial pressure, and sufficient urine output, ideally 0.5 to 1 millimole per kilogram per hour. In more complicated cases, especially in critically ill patients, additional physiological indicators like the correction of base deficit or lactate levels are used, as these reflect the adequacy of tissue perfusion and oxygenation.
And what about more advanced monitoring techniques for assessing volume status in complex postoperative patients?
Adjuncts to assessing volume status in the postoperative patient go beyond basic vital signs for those who are more unstable. These include dynamic measures like a passive straight leg raise test, which can predict fluid responsiveness, using point-of-care ultrasound to visualize the inferior vena cava's collapsibility, indicating volume status, and assessing respiratory variation via an arterial catheter in mechanically ventilated patients, which can indicate preload responsiveness. After the initial 24 to 48 hours, assuming normal renal function and adequate urine output, and provided the patient is not profoundly volume depleted, fluids can typically be changed to a hypotonic solution like 5% dextrose and 0.45% saline, especially if the patient is still unable to tolerate enteral nutrition. At this point, potassium may also be safely added to the IV fluids to meet maintenance needs or replace ongoing losses.
So it's not a one-size-fits-all plan that lasts for days. Fluid orders need to be adjusted daily, it sounds like, based on a dynamic assessment.
Exactly. Daily fluid orders should always begin with a meticulous reassessment of the patient's current volume status and any evolving electrolyte abnormalities. In an uncomplicated early postoperative course, there's rarely a need to check electrolyte levels every day unless specific losses or renal dysfunction are present. However, if there's significant postoperative diuresis, you do need to pay attention to replacing potential urinary potassium loss. All measured losses, from vomiting, nasogastric suctioning, surgical drains, and urine output, as well as estimated insensible losses, must be continuously replaced with appropriate parenteral solutions, always guided by the patient's evolving clinical picture and lab values. It's an ongoing, precise balancing act.
This brings us to a truly significant modern innovation in surgical care: fluid management and enhanced recovery after surgery, or ERAS, pathways. Pioneered by Henrik Kellett, how have these multimodal strategies transformed perioperative fluid management from the traditional approaches?
ERS pathways represent a paradigm shift in perioperative care. They are multimodal strategies designed to maximize and maintain preoperative organ function, attenuate the surgical stress response, and minimize post-operative complications. Their widespread implementation has dramatically improved patient outcomes, leading to decreased length of hospital stay, improved patient satisfaction, significant cost savings, and a notable reduction in overall complications. Perioperative fluid management is not just a component, it's a major cornerstone of these protocols, emphasizing a more physiological approach.
So what specifically changed regarding fluids within ERS protocols? I understand preoperative fasting recommendations, which were historically quite strict, were significantly altered.
Yes, that's a key and impactful change. The traditional NPO after midnight rule was challenged. The 2011 European Society of Anesthesiology guidelines, for example, were among the first to formally recommend altering standard preoperative enteral intake, now allowing clear liquids up to 2 hours prior to surgery. Many ERA's protocols also actively incorporate the use of carbohydrate and electrolyte-rich fluids administered orally preoperatively. The goal here is to enhance hydration and attenuate the metabolic stress response to surgery, essentially preloading the patient with what they need rather than letting them go into a prolonged fasted state.
And what about intraoperatively and postoperatively? Is there a deliberate focus on fluid restriction, moving away from potentially liberal fluid administration?
Precisely. A major focus of ERAS protocols is indeed the judicious restriction of intravenous sodium and fluids, both intra and postoperatively. The historical practice of administering large volumes of O5 fluids, sometimes referred to as liberal fluid administration, has been clearly linked to adverse outcomes, including prolonged ileus, that delayed return of bowel function, and coagulation abnormalities, both of which significantly increase complications and length of stay. The goal is to achieve euvolemia, a normal, healthy fluid status, rather than over-resuscitating. Goal-directed fluid therapy, or GDFT, which precisely guides fluid administration to achieve specific physiological targets, like stroke volume optimization, has been shown to reduce post-operative morbidity and length of stay. Even when integrated as part of a larger ERS pathway, it demonstrates its individual benefit in reducing major morbidities. Postoperatively, the emphasis is rapidly shifted to early enteral intake as soon as possible, with prompt discontinuation of intravenous fluids once the patient can tolerate oral intake.
So the overall outcome of these ERA's fluid strategies has been overwhelmingly positive, solidifying their role in modern surgery.
Absolutely. These strategies, which target strict euvolemia and a more physiological fluid balance, have been consistently shown to be safe and to significantly improve patient outcomes across a wide range of surgical specialties. ERS is a rapidly evolving and influential strategy that continues to shape perioperative fluid and electrolyte management for surgical patients worldwide. It truly represents a more physiological, evidence-based, and patient-centric approach to surgical care, moving beyond traditional dogma.
Okay, so we've gone through the general principles of perioperative fluid management, but now let's discuss special considerations for the postoperative patient, specifically two very common issues: volume excess and volume deficits. Let's start with volume excess.
Volume excess is indeed a very common disorder encountered in the postoperative period. It frequently results from the administration of isotonic fluids in quantities that inadvertently exceed the patient's actual physiological needs. This can be due to an overestimation of those tricky third space losses we discussed, or from ongoing gastrointestinal losses that are simply difficult to measure accurately, leading to over-replacement.
What's the earliest and most reliable sign of fluid overload post-op, and what are other critical indicators to watch for?
The earliest and often most reliable sign of true volume overload in the postoperative period is unexpected weight gain. A patient in the average postoperative period who is not receiving nutritional support should actually be losing approximately 0.25 to 0.5 pounds, or 100-200 grams per day, from normal catabolism. So unexpected or rapid weight gain is a significant red flag that mandates immediate fluid reassessment. Other signs, as we discussed earlier, include peripheral edema, swelling of extremities, pulmonary edema, fluid in the lungs manifesting as crackles or shortness of breath, and various cardiovascular changes like distended neck veins or elevated central venous pressure. It's also important to make a critical distinction. Peripheral edema doesn't always mean intravascular volume overload. You can have an overexpansion of total extracellular fluid that coexists with a relative deficit in the circulating plasma volume, which complicates assessment and requires careful clinical judgment to differentiate from true hypervolemia.
And on the flip side, what about volume deficits in the postoperative period? When do these occur and how do they present?
Volume deficits can certainly be encountered in the postoperative period if preoperative losses weren't completely corrected, if intraoperative losses were underestimated, or if postoperative losses like from drains, high output ostomies, or persistent vomiting were greater than initially appreciated or replaced. The clinical manifestations are, as we previously discussed, for hypovolemia: tachycardia, orthostasis, and oliguria, reduced urine output a key indicator of renal hypoperfusion. Hemoconcentration may also be present on laboratory analysis. Treatment will depend on the amount and specific composition of the fluid lost, but in most cases of straightforward volume depletion, prompt replacement with an isotonic fluid will be sufficient while you simultaneously evaluate for any alterations in concentration and composition. Careful monitoring of vital signs and urine output remains paramount.
Let's shift our focus now to specialized care. Electrolyte abnormalities in specific surgical patients. Certain patient populations face unique fluid and electrolyte challenges due to their underlying conditions or treatments. Starting with neurologic patients, there are three key, often confusing syndromes that clinicians must thoroughly understand.
Absolutely. Patients with neurological conditions have a particularly delicate fluid balance because the brain is exquisitely sensitive to osmotic and volume shifts. The first is the syndrome of inappropriate secretion of antidiuretic hormone, SIADH. This is characterized by the inappropriate secretion of ADH, meaning ADH is released not in response to physiological osmotic stimuli, like high osmolality, or volume-related conditions like hypovolemia. It effectively causes the body to retain too much free water. It's often associated with a wide range of CNS disorders, including subarachnoid hemorrhage, severe head trauma, infections like meningitis or encephalitis, or tumors. It can also be triggered by various drugs like morphine, NSAIDs, oxytocin, SCRIs, and certain chemotherapeutic agents, as well as pulmonary diseases. Small cell lung cancer is a common ectopic source of ADH, and endocrine diseases like hypothyroidism or glucocorticoid deficiency.
How do you definitively diagnose SIADH, differentiating it from other causes of hyponatremia, and what's the detailed treatment strategy?
SIADH should be suspected in patients who are euvolemic, meaning they have a normal clinical fluid volume status without signs of dehydration or overload, but are hyponatremic. They also have inappropriately elevated urine sodium levels, typically 20 MEQL, and elevated urine osmolality, typically 100 millivim AQ H2O, indicating concentrated urine despite low serum osmolality. The treatment involves correcting the underlying problem if possible. In most cases, the cornerstone of management is strict free water restriction, aiming for a net negative water balance. The goal is to achieve a gradual increase in serum sodium without compromising renal function. Furosemide, a loop diuretic, can also be used to induce free water loss by impairing the kidney's ability to concentrate urine. If hyponatremia persists after fluid restriction, judicious administration of isotonic or even hypertonic fluids may be effective. However, a crucial caution. Administering isotonic saline can sometimes paradoxically worsen the hyponatremia in SIADH if the urinary sodium concentration plus potassium concentration is higher than the infused sodium concentration. Loop diuretics can be helpful here by preventing further urine concentration and promoting free water excretion. For chronic SIADH, where fluid restriction is difficult, medications like dimeclocycline, which induces nephrogenic DI, and lithium can be used to induce free water loss.
So SIADH is about too much ADH, or ADH acting inappropriately. What about diabetes insipidus, DI, which is essentially the opposite?
Precisely. DI is a disorder of ADH function, manifested by the inability to concentrate urine, leading to dilute urine and consequently hypernatremia if water intake cannot keep up. There are two main types: central DI, which results from a defect in ADH secretion itself, often seen with pituitary surgery, severe closed head injury, or anoxic encephalopathy impacting the hypothalamus. And then there's nephrogenic DI, which is a defect in the kidneys' end organ responsiveness to ADH, meaning the kidneys don't respond to the hormone. This is associated with conditions like chronic hypokalemia, hypercalcemia, radiocontrast dye exposure, and certain drugs like aminoglycosides and amphotericin B.
How does DI affect volume status, and how is it diagnosed and meticulously treated?
In patients who can tolerate oral intake and have an intact thirst mechanism, their volume status is usually normal because thirst powerfully stimulates increased water intake to compensate for the excessive urinary losses. However, volume depletion can occur very rapidly and severely in patients who are incapable of oral intake or who have impaired thirst. Diagnosis can be confirmed by documenting a paradoxical increase in urine osmolality in response to a period of careful water deprivation, a water deprivation test, followed by a response to exogenous ADH. For mild cases, simple free water replacement may suffice. In more severe cases, particularly with central DI, vasopressin ADH can be added, typically 5 units subcutaneously every 6 to 8 hours, or continuous infusions of desmopressin, DDAVP. But it's vital to precisely monitor serum electrolytes and osmolality to avoid giving too much vasopressin, which could then paradoxically induce SIADH and iatrogenic hyponatremia.
And the third neurologic issue, cerebral salt wasting, CSW, often gets confused with SIADH. What's the key differentiator that sets it apart for clinicians?
CSW is a crucial diagnosis of exclusion, and differentiating it from SIADH is critical for correct management. It occurs in patients with a cerebral lesion, often subarachnoid hemorrhage, trauma, or tumor, and is characterized by renal wasting of sodium and chloride with no other identifiable cause for the natriuresis. The critical distinction from SIADH is that in CSW you see significant natriuresis sodium loss in the urine in a patient with a contracted extracellular volume. This contrasts sharply with the euvolemic state typically seen in SIADH. Hyponatremia is frequently observed in CSW, but it's a secondary event driven by the volume contraction and sodium loss. Therefore, unlike SIADH, the treatment for CSW involves volume and sodium replacement, often with isotonic or even hypertonic saline, rather than free water restriction. Misdiagnosing CSW as SIADH and restricting fluids can be disastrous for the patient.
Moving on to malnourished patients, specifically the potentially lethal condition known as refeeding syndrome. This is a major concern when starting to feed someone who has been severely malnourished. What's the exact mechanism and the severe, often overlooked consequences?
It absolutely is a major, potentially lethal concern that every clinician must anticipate. Refeeding syndrome can occur with rapid and excessive feeding of severely malnourished patients. Think chronic starvation, severe alcoholism, prolonged delayed nutritional support after surgery, anorexia nervosa, or even massive weight loss in obese individuals who have had bariatric surgery. The underlying mechanism involves a rapid and profound shift in metabolism. Before refeeding, the body adapts to starvation by shifting to fat and protein utilization for energy. Once carbohydrate-rich feeding is initiated, the body rapidly switches back to carbohydrate metabolism, triggering an insulin surge. This surge in insulin leads to a rapid cellular uptake of key electrolytes from the extracellular space, particularly phosphate, magnesium, and potassium, as they are drawn into cells for anabolic processes. It can also cause severe hyperglycemia due to a blunted initial insulin secretion and then profound hypoglycemia later.
So whether it's enteral or parenteral refeeding, what are the specific symptoms and life-threatening complications that arise from these electrolyte shifts?
The symptoms arise directly from these profound electrolyte abnormalities and can be severe and rapid in onset. They include cardiac arrhythmias from hypokalemia, hypomagnesemia, and hypophosphatemia, confusion, muscle weakness, respiratory failure due to diaphragmatic weakness from hypophosphatemia, and even death if unrecognized and untreated. Other issues can include fluid retention, edema, and vitamin deficiencies, particularly thiamine.
So how do you meticulously prevent or manage such a dangerous syndrome to ensure patient safety and recovery?
Prevention is absolutely key and involves a highly cautious approach. Before initiating any feeding, any underlying baseline electrolyte and volume deficits must be meticulously corrected. Additionally, thiamine supplementation, like a 100 milligram IV, must be administered before feeding begins to prevent Wernicke-Korsakoff syndrome, which can be precipitated by carbohydrate metabolism in thiamine-deficient patients. Caloric repletion itself should be instituted very slowly and gradually, starting with a low caloric load, say 10-15 kilocalories a day, and gradually increasing over the first week to 10 days rather than immediately giving full nutrition. Throughout this entire process, vital signs, fluid balance, and electrolytes, phosphate, magnesium, potassium, calcium, must be closely monitored, often daily or even more frequently, and any evolving deficits corrected promptly. This slow and careful, stepwise approach is crucial to avoid overwhelming the patient's system and prevent the fatal consequences of refeeding syndrome.
Our next specialized group is acute renal failure patients. The kidneys play such a critical and central role in fluid and electrolyte balance. How does their failure specifically impact things, and what are the unique challenges?
Renal failure completely transforms the landscape of fluid and electrolyte management, making it one of the most challenging patient populations. With the onset of acute renal failure, an accurate and dynamic assessment of volume status becomes absolutely mandatory. If the patient has prerenal azotemia, meaning kidney dysfunction due to reduced renal blood flow, often reversible prompt correction of the underlying volume deficit is the primary intervention. However, once acute tubular necrosis, intrinsic renal damage, is established, fluid management shifts dramatically. Daily fluid intake must be rigorously restricted to match urine output, plus estimated insensible losses, typically 500-800 ml per day, and any other GI losses. The goal is to avoid fluid overload while preventing further dehydration.
And what are the specific, common, and often life-threatening electrolyte abnormalities you frequently see and have to manage in acute renal failure?
Oliguric renal failure, where urine output is significantly reduced or absent, poses immense challenges. Close monitoring of serum potassium levels is critical, as hyperkalemia is common due to impaired renal excretion. It requires early, aggressive treatment and often emergent hemodialysis. Hyponatremia is also very common in established renal failure, often resulting from the continuous breakdown of proteins, carbohydrates, and fats, which generates metabolic water, coupled with the inadvertent administration of free water in IV fluids. Dialysis may be necessary for severe symptomatic hyponatremia. Hypocalcemia is frequently seen due to impaired vitamin D activation and hyperphosphatemia. It's important to verify by measuring ionized calcium, as many patients in renal failure are hypoalbuminemic. Hypermagnesemia and hyperphosphatemia are also common, as these ions are renally cleared. Phosphate binders are used to control hyperphosphatemia, but dialysis may be required for severe cases. Lastly, metabolic acidosis is commonly seen as the kidneys lose their ability to clear acid byproducts and regenerate bicarbonate. Bicarbonate can be useful for correction, but dialysis is often needed for definitive acid-base control. While dialysis can be intermittent hemodialysis or continuous renal replacement therapy, CRRT, CRT may offer advantages in hemodynamic stability and potentially improve renal recovery in critically ill patients.
Our final specialized group is cancer patients. They seem to face a multifaceted array of fluid and electrolyte challenges, not just from the cancer itself, but also from complex and aggressive treatments like chemotherapy.
That's very true, and it's a highly complex area. Fluid and electrolyte abnormalities are extraordinarily common in cancer patients, and they can be general issues seen in any severe illness or directly specific to the cancer type itself, the tumor burden, or its often harsh treatments.
Let's start with sodium in cancer patients. What are the common scenarios for hyponatremia and hypernatremia in this population?
For hyponatremia in cancer patients, it can be either hypovolemic or normovolemic. Hypovolemic hyponatremia often results from renal sodium loss, perhaps caused by diuretic use, or from cisplatin-induced nephropathy, a specific type of kidney damage caused by that chemotherapy agent. Cerebral salt wasting can also occur in patients with intracranial lesions secondary to their cancer. Normovolemic hyponatremia, on the other hand, is most commonly associated with SIADH, as many cancers, most notably small cell lung cancer, cervical cancer, lymphoma, and leukemia, can ectopically produce ADH. Certain chemotherapeutic agents can also induce SIADH. For hypernatremia in cancer patients, it most often stems from poor oral intake, which is very common due to nausea, mucositis, or anorexia from the disease or treatment. Significant GI volume losses, common side effects of chemotherapy-induced vomiting and diarrhea, are also major contributors. Central diabetes insipidus can also lead to hypernatremia in patients with central nervous system lesions from their cancer or after brain surgery.
What about potassium and calcium abnormalities in cancer patients?
Hypokalemia can develop from significant GI losses, such as profuse diarrhea caused by radiation enteritis, chemotherapy-induced diarrhea, or from specific tumors like villous adenomas of the colon that secrete large amounts of potassium. Conversely, hyperkalemia can be acutely precipitated by tumor lysis syndrome, which involves the rapid, massive destruction of tumor cells, releasing their intracellular potassium. For hypocalcemia, it's frequently seen after thyroidectomy or parathyroidectomy if the parathyroid glands are damaged or removed. Hungry bone syndrome produces acute and profound hypocalcemia after parathyroid surgery, as calcium is rapidly taken up by bones for remineralization. Prostate and breast cancer can paradoxically lead to hypocalcemia due to increased osteoblastic activity, which is increased bone formation, thus drawing calcium out of the serum. Acute hypocalcemia can also occur with acute hyperphosphatemia, as phosphorus complexes with and precipitates calcium.
And other critical electrolytes like magnesium and phosphorus in cancer patients.
Hypomagnesemia is a known and concerning side effect of specific chemotherapeutic agents like ifosfamide and cisplatin, which cause renal magnesium wasting. Hypophosphatemia can be seen in primary hypoparathyroidism, a less common cause in cancer, but possible, due to decreased phosphorus reabsorption, and critically, in oncogenic osteomalacia, a rare paraneoplastic syndrome that causes increased urinary excretion of phosphorus. Other causes in cancer patients include renal tubular dysfunction from multiple myeloma due to Bence-Jones proteins and certain chemotherapeutic agents. Acute hypophosphatemia can also occur as rapidly proliferating malignant cells take up phosphorus in acute leukemia. On the flip side, hyperphosphatemia can result from tumor lysis syndrome, where massive intracellular phosphate is released, or from the use of bisphosphonates to treat hypercalcemia, which can sometimes reduce phosphate excretion.
You mentioned hypercalcemia of malignancy earlier, noting it's the most common cause of hypercalcemia in hospitalized patients, not primary hyperparathyroidism. How does this specifically work, and what are the detailed treatment approaches?
Hypercalcemia of malignancy is indeed very common and serious. It typically results from either increased bone resorption, calcium release from bone, or, less commonly, decreased renal excretion. There are a few key distinct mechanisms that elite professionals must differentiate. First, direct bone destruction from widespread bony metastases, common in breast cancer, renal cell cancer, or multiple myeloma, where tumor cells directly erode bone. Second, some lymphomas, like Hodgkin's and non-Hodgkin's, can cause it by increasing calcitriol, active vitamin D formation, which in turn increases both calcium absorption from the GI tract and its mobilization from bone.
And the third, and perhaps most common mechanism, seems to involve a hormone-like substance that mimics PTH.
Yes. The third and very common mechanism is humoral hypercalcemia of malignancy, HHM. Here, tumors, especially squamous cell carcinomas, renal cell carcinomas, and some ovarian and breast cancers, secrete a parathyroid hormone-related protein, PTHrP. This PTHrP binds to parathyroid hormone receptors on bone and kidney cells, powerfully stimulating calcium resorption from bone and decreasing renal excretion of calcium, effectively mimicking primary hyperparathyroidism. This accounts for about 80% of hypercalcemia and malignancy. Treatment should initially begin with aggressive saline volume expansion, as this directly decreases renal reabsorption of calcium by correcting any associated volume deficit and increasing GFR. Once adequate volume status is achieved, a loop diuretic like furosemide may be added to further enhance renal calcium excretion. However, these initial measures are usually temporary.
So if those temporary measures aren't enough, what are the specific drug options for refractory hypercalcemia of malignancy?
There are several potent drug options. Bisphosphonates, such as pomegranate and zoledronic acid, are the cornerstone. They inhibit bone resorption and osteoclastic activity, preventing further calcium release from bone. They have a slow onset of action, 2 to 4 days, but their effects can last up to 2 minutes. Calcitonin is also effective, rapidly inhibiting bone resorption and increasing renal calcium excretion. It acts quickly within 2 to 4 hours, but its use is limited by tachyphylaxis, meaning its effectiveness diminishes significantly over a few days. Corticosteroids may decrease this tachyphylaxis and can also be used alone for certain cancers, like lymphomas. Gallium nitrates are potent inhibitors of bone resorption with a longer duration, but they carry a significant risk of nephrotoxicity. Mithromycin, an older antibiotic, blocks osteoclastic activity, but its use is severely limited by potential liver, renal, and hematologic abnormalities. For severe refractory hypercalcemia, especially in patients who cannot tolerate aggressive volume expansion due to pulmonary edema or congestive heart failure, dialysis is an effective option for rapidly removing calcium.
Finally, another critical and life-threatening complication in cancer patients is tumor lysis syndrome, or TLS. What happens here? What are its specific consequences, and how is it meticulously managed?
TLS is an acute, life-threatening oncologic emergency that results from the rapid lysis or destruction of a large number of tumor cells, typically in response to chemotherapy or radiotherapy, though it can occur spontaneously. This massive cell destruction overwhelms the kidney's excretory capacity with the rapid release of intracellular metabolites. This leads to a profound and dangerous metabolic derangement characterized by marked hyperuricemia from nucleic acid breakdown, severe hyperkalemia from intracellular potassium release, severe hyperphosphatemia from intracellular phosphate release, and consequently hypocalcemia as phosphate complexes with calcium and precipitates. Ultimately, this leads to acute renal failure. It's typically seen with rapidly proliferating and chemosensitive tumors, such as poorly differentiated lymphomas, like Burkitt lymphoma, and acute leukemias, but can also occur with certain solid tumors.
And the meticulous management for TLS. Does it involve the same correction principles we've discussed, but with critical nuances?
Much of it, but with very specific nuances that must be mastered. Once TLS develops or is anticipated, aggressive volume expansion with intravenous fluids should be undertaken immediately to promote renal excretion of the metabolic byproducts. All associated electrolyte abnormalities must be corrected. However, a crucial and counterintuitive point here is that hypocalcemia in this setting should not be treated unless it is severely symptomatic, like with tetany or seizures. This is because calcium administration in the presence of extremely high phosphate levels can lead to metastatic calcifications in soft tissues and kidneys, worsening renal damage. Allopurinol or resburicase are used to reduce uric acid levels. Dialysis may be required for managing impaired renal function, for correcting severe refractory electrolyte abnormalities that don't respond to medical management, or for fluid overload. It's a complex and high-stakes condition requiring vigilant monitoring and precise, multifaceted interventions. #outro.
Wow. We've truly performed a deep dive today. From the intricate dance of ions across cell membranes and the precise formulas that govern their movement, to the sophisticated strategies guiding patient care before, during, and after surgery, this balance of fluids and electrolytes is truly fundamental to life itself. We've seen how even subtle shifts can have profound, often life-threatening effects, and how precise, knowledge-driven interventions are absolutely critical for survival and recovery, demanding a mastery of these core physiological principles.
It's an incredible testament to the body's adaptive complexity and the rigorous, detailed work required by medical professionals to maintain this delicate homeostasis. The depth of understanding required to master this field is immense, covering everything from basic biophysics and cellular physiology to advanced pharmacological interventions and the nuanced presentations of various disease states. It's a constant challenge and a constant learning process, even for seasoned practitioners.
What stands out to you from this intricate web of physiology and treatment? Perhaps it's the body's remarkable compensatory mechanisms, or the sheer number of factors clinicians must consider and precisely quantify for each individual patient. For me, it's the realization of just how dynamic and precisely balanced our internal environment truly is, and how every little number on a lab report tells such a vital story.
For me, it's the constant interplay between seemingly disparate systems. How correcting one imbalance, like magnesium, is absolutely essential for fixing another, like potassium, or how an apparent electrolyte issue is often a symptom of a deeper volume problem. It really underlines the importance of a holistic, integrated approach in patient care, recognizing that everything is interconnected. The body isn't a collection of separate parts, it's a symphony of finely tuned systems.
And as we look to the future, consider how advancements in personalized medicine and real-time monitoring, imagine continuous, precise electrolyte sensing, might further refine these gold standards of care. How might truly mastering this fundamental science, down to the mill equivalent and millius mole, unlock even greater healing potential, allowing surgical patients to not just survive, but truly thrive and recover their full potential? The journey to optimize homeostasis is an ongoing one, with constant learning, innovation, and refinement at its core.